At Spine West, we specialize in physical medicine and rehabilitation, also known as physiatry, a unique blend of orthopedics, neurology, and internal medicine. We are experts in motion and function. We evaluate and treat the whole person, including joints, muscles, and nerves. The providers at Spine West are experienced physicians, award-winning and published, with multiple board certifications, who treat all types of patients, from elite athletes to the very frail. We believe in our motto: trust, care, excellence. Our mission is simple: promote health, hope, and function, and to prevent injury. Our on-site advanced diagnostic and treatment technology gives you the best answers and the best treatments efficiently. This saves you time and money, so you can heal faster and return to the activities you love. We help you understand your condition and develop individualized treatment plans. We treat patients with respect, like we would our own family. This is why we are trusted by our patients, our peers, and the community. Call us if you have questions or if you'd like to make an appointment.
Hi, this is Cliff Gronseth coming to you from the Spine West webinar series. Today we're going to talk about knee pain, some of the advanced treatments that we're doing in the office here, non-surgical, and review some of the anatomy and main causes of knee pain in general. So it's going to be a quick overview. We'll try to address the questions as they come in. If you can try to keep the questions a little bit more generic so that the whole audience that's watching would appreciate, versus a personalized immediate consultation, which I probably won't address. So that being said, let me just jump into the overall view. What I'm going to do is I'll review the main causes of knee pain, some of the anatomy, and then we'll talk about some of the treatment options that are available that are non-surgical. At Spine West, we practice most of the non-surgical options for different orthopedic issues. So just a quick overview. The knee, of course, is the hinge joint. It's a major weight-bearing joint of the body, and it is a very common source of pain. The core of the knee is made up of four main bones: the femur, the tibia, and then the kneecap, also called the patella. The other one is the fibula, which really doesn't add a whole lot to the knee other than muscle attachments, and it's usually not a source of pain. So oftentimes the main focus of pain generators is within the joint itself. If you go from deep to superficial, the bones are covered with cartilage, which is like a tough Teflon that allows the bones to glide on each other. And those are the knee joint is then surrounded by ligaments that you can see up here. We have ligaments on the inside, outside, and also inside the joint itself. If you've heard of anterior cruciate ligament, etc., that sits inside the knee and provides stability. The ligaments themselves are usually not injured unless there's trauma. So those are oftentimes a structure that is not something that develops over time. It should be a painful structure that develops over time, but rather an acute injury from a fall, etc. There are nerves and blood vessels around the knee that we'll talk about a little bit later, which we are now maximizing for trying to decrease pain around knees, especially either post-replacement knees or people who don't want to get the knee replacement, even if they're a candidate. And then, of course, the knee has a multitude of muscles that surround it, and those also can cause problems. But again, those are mostly for an acute traumatic injury, not so much a chronic degenerative type of problem. And then there's some little sacs of fluid around called bursa, which can sometimes be a source of pain. So in general, the grouping of pain is either an acute traumatic event, which can be a bone fracture, ligament tear, muscle tear, or a chronic condition, usually either wear and tear, such as arthritis, osteoarthritis, or a rubbing type of repetitive stress or repetitive injury type pain, which comes oftentimes with runners, or if somebody did a long hike that was atypical for their activity pattern, that will sometimes induce some local irritation, some friction underneath tendons, which can then cause pain. Those types of issues are usually short-lived. It's really the degenerative type of problems which cause some of the ongoing chronic painful conditions that we have the most difficulty with. I will look at some of the structures with ultrasound. We've set up an ultrasound machine here just to show some of these structures with some of the ultrasound findings. So I'm gonna quickly give you a tour of the knee and show you what some of these things might look like. So this area right down here is the femur. You can see that little white arrow. That's bone down there, and the rest of the tissue above is either muscle or the skin layers. If you follow this fibrous muscle down, you'll see that it will attach to the kneecap coming right down here. Yeah, let me get more gel. And right down here, and you can see there's a little bright white line right there. That is the kneecap where the muscle attaches. That is oftentimes a site for degeneration and some tearing, etc. If you go further down past the kneecap, then you see this fiber right here, which is one of the ligaments. It's the patellar ligament, and it attaches the kneecap to the leg bone called the tibia. Now, if we go back up, you can actually see a layer on top of the bone, and that is the cartilage. I'll try to get it dialed in here. I'll do a cross-sectional view of it, and there's a good view. So you can see this nice curved white line coming down here, and right on top is this uniform thickness black layer right here, and that is the cartilage that you see right along the top of the bone there, and that is what thins out over time and is known as degenerative osteoarthritis. So this knee that I'm working on happens to be in the 20s, so there's still lots of cartilage left. When you're 3, 4, 5 times that age, that cartilage thins out, kind of like brake pads in your car or the treads in your tires. They'll start to thin. So that is a major source of chronic pain, repetitive osteoarthritic type of pain. So what are the options for the different types of knee pains? For the acute injury, such as a fall, etc., the best mnemonic is RICE, R-I-C-E, which stands for rest, ice, compression, and elevation. So that addresses the swelling which develops from an acute injury, and compression is actually the most important of all those three, and they then top that with the ice. And then the rule of thumb is if it hurts, don't poke the bear. Don't kind of make it hurt and do things that aggravate it, because that simply just, you're working against yourself. Your body is telling you, hey, this is not okay to do in an acute injury setting. And so you really should respect the pain until that settles down. Typically that can take anywhere from 2 weeks to 2 months, depending on how bad the injury was. In a chronic condition, however, sometimes you have to bully through the pain, and it is a little bit of a fine line between what's potentially harming and what is helpful. A physiatrist is focused on function. We try to just keep you moving any way, shape, or form. And if the condition is causing functional limitations, it really needs to be worked up to make sure that it's not a dangerous type of pattern, and you can actually work through it if you need to, or you may need to truly respect the pain and not go into that area. The other potential source of pain, which I did not mention, was referred pain. And sometimes hip arthritis or a pinched nerve in the back will produce pain in the knee. And some people think, well, the problem's in my knee, and then they find out that it actually is coming from elsewhere, which is a completely different type of treatment and workup plan for people. So my suggestion for the acute conditions is respect the pain, wait for it to settle down over time. For the chronic conditions, make sure you know what you're dealing with, and then we'll treat it accordingly. Now, the typical treatment options for a chronic knee pain condition is going to be either physical therapy to work on the muscles that around the knee, align the knee well with bracing either with the foot, or perhaps a brace around the knee to try to offload the painful area. For example, if you have knee pain because only part of the cartilage is worn out, just on one side of the knee, just with simple foot orthotics and realigning the angle of your foot might change the mechanics of the knee joint and offload that worn out segment in the knee, and just simple shoe inserts may be enough. Alternatively, you might need a full brace that actually pushes the knee sideways so that it really offloads that area, so it's not rubbing and grinding as much. The pain medications are either swallowed with pills, topical on the skin, or injected. And there's different types, depending on how deep the problem lies, will determine what type of medication we'll use. We'll oftentimes try oral medications, and if that doesn't work, then we might inject the knee with different types of compounds. The first thing we'll usually do is corticosteroids, which is a strong anti-inflammatory medication. You can do that a time or two, but you don't want to do that repeatedly, because it can actually induce some of the cartilage to soften and wear out over time. So then we switch over to some of the newer medications that have come out over the past 10 years or so, something called orthobiologics, which include things like hyaluronic acid, or hyaluronate. Some people call it rooster juice or WD-40 for the knee. It basically is it's a material that your body makes inside the knee joint, but we put it in higher concentrated amounts, and it in essence somewhat lubricates the joint without causing any undue harm to the structures within the joint. So that's usually a series of 3 or 5 injections for those that are familiar with it. But it can become quite helpful for some people, and thereby avoiding excess steroid use. The other newer agents that we're injecting into the knee are stem cells and platelet-rich plasma, and other types of regenerative medicine materials. Now, there's still a lot of research to be done in that field, but there are some anecdotal successes for those types of products. They are a bit expensive. The insurance doesn't pay for those types of treatments, but they're safe because they are. It is your own material, your own stem cells, and your own blood that's used to inject back into the knee in hopes of trying to cause decreased inflammation and perhaps a little bit of cartilage growth. Again, research is still far behind the actual marketing of the regenerative medicine. You'll hear many ads, etc., out there, but again, it is a safe procedure overall. We've been doing the regenerative medicine injections for over 10 years, and for the right person, it might be appropriate. The latest treatment that we're doing for people with kind of end-stage knee arthritis, people who either have already had knee replacements or are trying to hold off on getting a knee replacement, or they're not candidates for knee replacements at all, but they do have a lot of arthritic pain. We are now starting to cauterize the nerves, the deep nerves within the knee that run along the bone. You can see here these little kind of red little strings down here, and then there's one at the bottom of the knee here. Those 3 areas are accessible with special procedure, with X-ray guidance and sometimes ultrasound guidance, and if with a special machine or a probe, we're able to place needles right along the nerves, and we can heat them up and cauterize them, and that decreases the sensory input, kind of the pathway for the pain to get up into the spine and the brain, so that it somewhat tricks the body so it doesn't feel pain as much. It's not 100% pain relief, so there are always concerns, am I going to harm myself more if I don't feel anything? And it's not that good, but there are some folks who really respond to this type of procedure, and it's very promising. People that have had knee replacements and they still have knee pain despite the artificial knee, are sometimes able to get some pain relief by cauterizing those nerves around the knee. They're called perigeniculate knee nerves. So that's another advanced option that is available for folks to consider if you have end-stage knee arthritis. We would not do it on a 20-year-old knee or somebody that still has lots of miles left in their joint. But for those that are, trying to hold off on knee replacement surgery, which is a great surgery for the appropriate folks, but those who are not keen on getting a new knee, then that might be another option. So those are some of the that's a brief overview of the knee anatomy, some of the common causes of knee pain, and some of the more advanced treatment options. If you have questions, certainly come on in. We can talk about it in person and see what you may be a candidate for. And hope this was helpful. Please send suggestions for other topics, and we will be happy to put on a webinar specifically for you per your suggestions. Thanks so much. Have a great day.
Physiatry, Also known as physical medicine and rehabilitation, or PM&R for short, is the best-kept secret in medicine. Physiatrists specialize in restoring movement and function without surgery. They are specialized, board-certified physicians, muscle, nerve, and joint experts who treat problems that affect how you move. They strive to maximize your performance no matter what your age or circumstances. Physiatrists are experts in diagnosing and treating various joint problems, back and neck pain, leg pain, weakness, and numbness. They get specialized training in nerve and muscle function, physical exam techniques, biomechanics, gait analysis, bracing and prosthetics, and pain management. The history of the specialty dates to the 1900s, when veterans injured in war and children disabled by polio or cerebral palsy were medically stable but physically not ready to return home. Using innovative techniques, certain doctors help guide these patients to promote healing and achieve their maximal function. In the 1940s, the American Board of Medical Specialties acknowledged physical medicine and rehabilitation as a unique specialty, filling the gap between orthopedics, urology, and general medicine. Today, the benefits of physiatry, with their focus on function and non-surgical care, are fueling strong demand from the very frail to the very athletic. Working closely with other physicians and care providers, they treat the whole person, not just the problem area. They accurately pinpoint the source of your problem. And through teamwork, they help patients achieve more with their medical, social, emotional, and vocational issues. Each patient receives individualized treatment plans using appropriate therapies, directed exercise, medications and supplements, modalities such as electricity and ultrasound, specialized bracing, and advanced pain management treatments. And most importantly, they guide you on how to avoid injury in the future. Physiatrists strive to improve your function and maximize performance so you can feel better and do the things you want to do. Call us if you have questions. The team at Spine West looks forward to helping you.